Well, good morning, good morning, good morning. We're ready to start. We love starting on time, and today it's very important that we stay on time because we got to be out of this building pretty quick this morning and out of the parking lot as well. We have a little game tonight. My alumni has decided to push us around a little bit, and we're glad to accommodate them. But so we're going to start with the Department of Human Services here. Sean, if you want to come on up. Yep. Yep, at the podium, please. And while they're going up, make sure that the members give Stacy their mileage and the number of days where we can file that. And I think that's it. All right, Sean. We're ready for you. Thank you for coming.
Oh, no problem. Good morning, everyone.
Good morning.
All right. My name is Sean Johnson. Excuse me. I am the Senior Director for the Caregiver and Wellbeing section at the Division of Family and Children Services. And then LaShawn Denard is the South District Director. All righty. So you all know that our mission is Stronger Families for a Stronger Georgia. So here, this is the data regarding hoteling. And so hoteling is for kids that are considered to be without placement. And so we've been capturing data since 2020. If you see on the far left, when we started was 9/1 of 2020. And then up until this data is going to be until 9/27 of 2023. So if you see the data is constantly, when it started in 2020, it was going up, and up. I wish I had a thing where I could see it. It was going up, and then it peaked. If you look at the date of 6/28 of 2023 is when the data peaked, and it tells you right here that we had approximately 90 plus kids that were without placement. And so at that time is when we recognized that it was some things that we needed to do. So we're going to get into those things that we needed to do. So what I wanted to do is give you a little bit of background so you can understand what is placement. So kids can be placed either in a DFACS foster home, so that is a public home, or they can be placed with a private agency. And a private agency foster home is considered to be with a child placing agency, and we call it a CPA. And those CPA agencies, just for you to know, a couple of the agencies' name that is over in this area is Bethany Christian Services, Seeds That Grow, Coastal Harbor, CPA, Wellroot, NECO, and NIAP. Then a child can also be placed in a congregate care. A congregate care is a CCI and what is known as a group home. And a group home can range from a base level facility with 6 kids up to a larger facility. And some of our larger facilities are places like Twin Cedars, the Methodist Home, Georgia Baptist, and Kids Peace. Then we also have what is called a psychiatric residential treatment facility. That is a PRTF. And a PRTF is considered to be a hospital, and it is managed by DCH. That is the Department of Community Health. And the funding is received by AmeriGroup. Any questions regarding types of placements? Okay. Go ahead.
Tell me about I'm on the board at the Methodist Home, but
Okay.
I used to be on the board at the Boys Ranch. Why isn't the Sheriff's Boys Ranch listed up there? Because they do a great job.
It's just we just capture a couple of the providers, but yes, the Sheriff Ranch is one of our providers, and they absolutely does a great job with our kids.
All right,
We
thank you.
just we couldn't list everyone.
Oh, okay. Thank you.
Oh, no problem. So here are some of the characteristics of kids that are without placement. And so when we're talking about kids that are without placement, these is because of sometimes because of their complex needs. And some of those kids, they have extensive criminal history. They're violent offenders and they're designated as felons. They have sex crimes, juvenile and adult criminal charges. Some of these kids have placement restriction, meaning that they may not be able to be placed with younger kids, or they may not be able to be placed with someone of the same sex or the opposite sex. So it's many restrictions regarding this population. And in some of these kids, they have complex needs, medical needs. That means some may be experiencing diabetes, seizures, with a combination of behavioral challenges. So not only there's concerns about your medical health, but there's also concerns regarding your behaviors. So it makes it difficult to find a placement that is willing to support a child's medical needs as well as their behavioral health needs. And often these kids, they come into our care from the bench. So it's not like we went into a home and found that there's abuse and neglect. It's been the decision that has been made by the judge to say, hey, this child needs to come into care. And so when that child comes in off the bench, it becomes difficult to find that child a placement. And some of our kids between the population, the age group of 18 and 22, they have developmental disabilities. And with those developmental disabilities, what we're doing is working with DBHDD, which is the Department of Behavioral Health. We're working with them to identify a placement for that child. And at times it's a process. And so when that child goes on that non-comp waiver, sometimes it can take up to a year to find that child a placement. Then we have youth who have dual diagnosis. So that means that child have multiple diagnosis, and you may have a facility that is willing to work with one diagnosis, but not the other. So it becomes difficult. And so those are some of the reasons, some of the characteristics of the kids that are without placements, that have been without placement. So you ask, how did we get here? We got here because how many of you heard about Families First? Okay, so Families First, that was is in reference to reducing congregate care. So the goal is to move kids from being placed in group homes and more in family foster home setting. And so when that took place, then we had a number of our CCI providers, which is the group homes, made a decision to say, hey, because we're knowing that the division is going to be focusing heavily on foster homes, we're making the decision to close our doors. So we had a number of our group home providers to close their doors because of the Families First Act. And then COVID-19. The pandemic. And then with COVID-19, we had a number of providers that started experiencing workforce issues. And that meaning that after COVID-19, a number of staff no longer wanted to work. And so because the staff no longer wanted to work, then that became a reduction in the capacity of a provider. So we had a provider that had a capacity of, let's say, 40. And they were staffed up, meaning they had 100 direct care staff workers. And then by COVID-19, a number of those staff disappeared. So then now, once you had 100, now you're down to 50. And so because you're down to 50 and your capacity to accept 40 kids, you had to make a decision as a provider. You needed to decrease your capacity based upon your staffing. So we had some providers who were at the capacity of 40. They went to the capacity of 20. So if they can only take 20 kids and they used to take 40, that hurt us regarding placements. And then also what we found out, we did a rate study with our providers. We found out that a number of providers were only paying direct care staff between $13 and $15. And we know that most of those staff can go to Walmart and Target and make more money. And then you're thinking about you're working at a group home facility with working with children with complex needs versus you can go to Walmart and only thing you have to do is deal with customers. Which one are you going to take and make more money? So what we did was we worked with providers, and now what we're looking at doing is how can we possibly increase the per diem rate for providers? And so we're going to go into that in just a second. And then also what we found out, it was a reduction in community-based services. So when families were experiencing crisis, they were unable to go into the community to receive those support services. And so what ended up happening is they were saying, hey, we need DFACS to come get our kids. And they no longer were willing to work with us because they didn't feel like they had the support within the community. Okay.
Thank you. Just a real quick question. Who sets that 1-to-6 ratio? Does the state set the
The
ratio?
state does.
Okay.
Go ahead. It was passed by Congress.
Because I really feel like I see some instances where, especially young boys in middle school are better, like at the ranch where you have a lot of activities and you have tutors all the time and all that are really better off than they are in a foster kid when the foster parents work
Yeah.
and can't take them to all these activities. I just have a little problem with that.
Yeah. And the data proves that.
Uh-huh.
All right.
To the members, can we hold our questions until after the presentation? please? Thank
Okay.
you.
That's to Penny.
Not to you, not to Madam Chair.
Shut up, Casey and Penny, shut up.
Okay.
I'm glad you're here today.
Go right ahead.
Okay. So, how is the agency addressing youth with complex needs? These are some of the things that we are doing. So for case-specific strategies, what we've done is hire attorneys within the division, additional attorneys. And so because what we found out is a number of our kids, the services that our kids are needing were being denied. So we hire expert Medicaid attorneys so we can fight with our medical insurance provider to ensure that our kids are receiving services. So that has been found prudent. Then what we also have done is we hired a complex care coordinator. And so that coordinator, she is responsible. So you remember that first data point that I showed? She is responsible for tracking all of the data for all of the kids with complex needs. And then what else she is responsible for doing is doing weekly calls with LaShawn's team, North District and Metro District. And so on those weekly calls, what we're doing is staffing each child. So if a child is potential about to disrupt a placement, or if a child has disrupted placement, or if a child is without a placement. So we're doing weekly calls to address those kids to make sure that we come up with a plan to address those needs. Then also what we've been doing is we have been educating our providers around AmeriGroup, who is our medical insurance provider, DCH, and PRTFs. And what we've been doing is staffing those kids with those individuals as well. Some of our systemic strategies is we increase the rate. We started paying providers $150 in an addition to the per diem that they were already receiving. So say, for instance, a child is with the program designation of maximum watchful oversight, and that child is receiving $190 a day. So we added on top of that $190 a day, $150. We did that to our private agencies, to our foster parents, and we also did it to our DFACS foster homes. And so when y'all see the decrease in the numbers starting from July of this year up until present time, it was because of those enhanced rates. And then what else we did was we hired a staffing agency to be able to support 7 of our largest providers who were having staffing issues. So we paid a staffing agency to be able to go out and support our group homes. And then in addition, like I spoke a second ago about AmeriGroup, we're having regular meetings with AmeriGroup discussing our need. And in reference to that, that has shown that a number of our kids' support services that were needed, they started to receive those. And we increased our engagement with DBHDD. We had 2 kids that were in hotels for quite some time. One was 20 and one was 21. And both of them were on the planning list for DBHD. And like I told you before, that planning list, that child can be on that list for up to a year. And our commissioner for the Division of Family Children Services and the commissioner for DBHDD worked together, and we finally was able. So those last 2 kids that were in the hotel, it was because we couldn't get them into a DBHDD home. And then finally, in the beginning of August, they were finally placed in those homes. And then also we increased our engagement with DJJ regarding kids that are coming into care off the bench. So having conversations about who should be responsible for those kids, if it's DFACS or DJJ. And so we've been working collectively together. And what we have to always make sure we tell everyone, hotel is not a placement. It's not a placement. And so when I spoke about July of 2023, the work that we did, our Deputy Commissioner, Mary Havoc, what she did was she employed all of the regional directors and the district directors. Before you can make a placement into a hotel, you had to submit what is called an SBAR. Submit the SBAR to us, we review it and review all of the work that had to be, what was done for that child to make sure that a placement could have been solidified and not a hotel being the first option for this kid because the kid was difficult. So it was all hands on deck. And what we started doing was having weekly cadence on Friday, and we staffing each kid again with the executive leadership. And from there, now, as of today, as of last night, we only had 1 child that was in the hotel. And that 1 child that is in the hotel is a child that is actually from Ohio and having to be transitioned to Ohio. So the work from July up until present time, those 90 plus kids, this process, it worked. And we require providers to give us, who was giving us less than 14 days notice to have a child removed. We were having conversation with those providers. So before, what we would do is take the notice and then automatically start looking for placements. It was no longer that case. What we were telling providers, if you want that child discharged, what you have to do is work with us to help secure another placement, and that child is not being discharged to a hotel. That child had to be discharged to another placement. And then what we did was we increased the emphasis on accountability, just what I just said. It's no longer the division issue by ourselves. We're making sure that everybody is aware because it's a system issue. And so making sure that all parties are a part of the decision. If that child, if it needed to be DBHDD, DCH, AmeriGroup, who all needed to be involved, we made sure that they were involved. And what we also had to make sure providers knew, just because we changed the placement of the child, that does not change that child's needs. The needs of that child at this placement will be the same needs of the child at the next placement. So what can we do at your placement to stabilize this child? So work together collectively as a team. And as I stated before, executive leadership was a part of this. We had the commissioner making calls to providers. We had a deputy commissioner making calls. LaShawn, myself, we were all involved in this process. And because we were all involved in this process, we've been successful in reducing the numbers. I'm going to turn it over to LaShawn.
Thank you, Dr. Johnson. The last final slide is the rural foster care needs. I am the District South Director, and I have all of the counties south of Macon all the way over to the Augusta line and to the Florida border. So out of the 159 counties, I have 100 of them, with most of them being primarily rural communities. And so, as Dr. Johnson spoke earlier, even in the field operations, which is where I work, which is interacting with the county staff in the communities in which we have our local offices. And what we have found is that there is a great need for increased mental health services for both our adults, parents, and our youth that we support. There's also an increased need for resources that provides extensive supports to our children who are in mental health situations where they are in crisis. This is not only in a hospitalization type setting, but with our local mental health folks, that when we as an agency are trying to support children to keep them in their homes with their parents, there's a need for outpatient services. And so we're seeing that that's been a deficit in many of our communities in rural Georgia. Another thing that we struggle with is placement resources for children with complex needs. Although we don't have outpatient services to the degree in which we need, but in many of our rural communities, we do not have opportunities to place them in facilities that will help them if they need long-term care. Oftentimes that means us taking them, transporting them to the Atlanta metro area or to other areas, taking them away from their community, taking them away from a place where they feel safe and secure, where they may have security by just being a part of a church community. So those are things that we really struggle with. The other piece that we are missing and we need in our rural communities are increased opportunities to support our youth who have problems with addiction, and our adult parents that suffer with addiction. As an agency, we've used many of our resources to connect with providers who are willing to do treatment in the home, but oftentimes that still is not enough. And so we recognize that there is an increased need for those types of supports for our youth and our parents. And then lastly, you all know we say this quite often, there's always a need for us to develop more foster parents. But one of the things that we have really been strategic about within the agency is looking at how we can develop homes with not just with our regular foster homes and with our CPAs and other partners who have foster parents, to look at how do we supply the resources and skill sets to help to develop foster parents who can parent children with complex needs. And so as you see here on the screens, if you know anyone, this is something that you can take away with you as a tangible item, that if you know anyone in your community, if any other local organizations that you may be a part of, that to share this number, 1-877-210-KIDS, and they will get information about how you can foster and or adopt children in the state of Georgia. So that concludes our presentation. Not sure if there are any additional questions.
Thank you for the presentation. We do have some questions. The chair recognizes Chairman Perkle.
Thank you, Mr. Chair. So do I need to hold it down? I'm good? So I actually have one for each of you. That's okay. So the first one, would that be okay, Mr. Chair, to have a two-pronged question?
Yes.
Okay, so the first one that deals with hoteling. It's my understanding from your presentation that it is still an option, but it is the last option. And so as a general rule, would you say that the kids that are being hoteled now, not last night, but as a generally, they have multiple problems. So felons, they are, you know, what Granny might call bad kids, that would be a danger to other children, would be a danger to a foster parent, and they have specialized needs that you cannot have in a regular environment. And so it is still an option for kids that there are no options for until we find directed care in a secure facility that can keep others from being hurt. Is that correct?
That is correct.
That was a long question to get to the first. Is that not true? And so the second one has to do with some of our defects office. So I had a constituent last week call me, and he said, "Man, I can't get anybody at defects. Nobody's there. Do you make this call on you call this number and go through this phone tree thing and leave a message and you hope somebody calls back." And my concern is if you are the agency of our reporters of problems that we see in our kids, whether it's from a teacher or from a community leader, from a church member, and they have concerns about the care of and they see something, you say something. If you can't go in the office and say something, and you're relying on a phone tree, I don't know how many of our offices are open, if they're all open, or if
They're not.
I'm getting a little bit of different answers to that question. Constituents tell me I can't get through, and I need to make sure it's kind of important we have people in place.
So let me try to start by, and I'm not sure if the calls that you're receiving from your constituents is coming from folks who are having questions or concerns around eligibility type items, food stamps, Medicaid, and TANF questions. But for Child Protective Services increase, we have a call center number that is manned 24 hours a day, 7 days a week. That is where they can call. Most of our mandated reporters, like your teachers, law enforcement, hospitals, they have that number. They also have access to our on-call schedule and phone numbers where they can reach out and call to make a report at any given time. Now, there is a slow staggering of offices being open based on certain days a week regarding having access to clients for food stamps, Medicaid, and TANF.
Why is that?
It's staffing challenges.
Okay.
But we are, and then one of the things, we have had an influx in the number of folks who are applying for benefits. And so one of the things we've done is utilize a majority of those staff to be able to work on those cases so that we can expedite getting families cases processed so that they can get their benefits timely. But there is a mechanism for child welfare cases to be called, reports to be made, and most of those folks, as I said, the mandated reporters, they have access and they know how to make a report. And anytime, if the doors are open, even if they don't feel like I know how to call that 1-800 number to make a report, we will have someone in office that will listen and take the report and then share it with our call center so that we can make sure that we disposition that report and that inquiry appropriately.
Okay. Thank you.
Thank
You're
you.
welcome.
Chair recognizes Representative Al Williams.
Thank you, Chairman. I have a Representative Perkle-like question. It won't take quite as long, but Adam Newell, I know you probably don't have it with you, but I would like to have a listing of those counties that don't have the resources that you've mentioned. And I'd like for the department to let us know what's the cost and what's the need? What are the real needs out there? Secondly, and finally, things have changed a lot at DFACS and that sort of thing. I know you're staffing problems, but from a personal standpoint, and I send to different areas to get in touch with you all, but there's been a local disconnect. I remember working hard to get the money to build a new office in Hinesville. And then you started further up in McIntosh and Glenn counties having these multiple county directors. And I hate to say this, but I wouldn't know my director's name. And we have a lot of people we have to see. And to me, this is something Grandma taught me. You don't wait for folk to meet you, introduce yourself. Looks like when you come in and you're the director, and you all have to come to us for a little bit of money every once in a while, you would say, I'm such and such a one, like for you to stop by. There is a disconnect. But I would like to know where those resources are lacking and attach a cost. And you have not because you asked not. I haven't heard anyone step forward at any of the appropriations hearings and say, here's specifically where we're deficit and here's what we need to fix that deficit. Okay.
Thank you. We'll make sure that we get the information, to request the information back to you and the committee.
Chair recognizes Chairman John Corbett.
Thank you, Mr. Chairman. Question and a comment. You might have said, how many kids do we have in foster care now in Georgia? Did you say that number?
It was just, yesterday, it was a little over 11,000.
11,000. I know at one time, a few years ago, it was 15,000.
Yeah, we're a little over 11,000.
So it's down to 11. And the other was just a comment, and one of the main complaints I get or calls with DFACS has to do with adoption process. When a foster parent decides to adopt, the gauntlet that they have to do to terminate the TPR notice from a judge is so hard to do. It seem like the pendulum has swung so far the other direction to try to put the child back in a bad situation. And I don't know how we fix that problem, but I mean that's the biggest complaint I get when somebody decides to adopt. It's about impossible, and it makes them where if in the comments that that they'd never foster a kid again, they get attached to it, and then everything they do to take it and put it back in a bad situation.
Chair recognizes Chairman Penny Houston.
I know this is a lot to ask, but in rural areas, my biggest people call all the time that there's nobody at DFACS, nobody answers the phone, nobody's there. Could you please give the rural? Would you please give the rural representatives the hours of operations of their DFACS, so when the constituents call, we can tell them what time, and we can put it on our Facebook page when DFACS is open. Can we have the hours of operation of each county DFACS?
You would like, the normal office operation hours are from 8 to 5 a.m.
What
5 p.m.
days a week?
And it just depends on the class size. But what we can do is get to the committee a copy of the schedule of operations for all of the county offices. We can
And
commit
then
to doing that.
somebody's there. When you go by there, somebody's there.
There should be somebody there during the times of
Okay.
that's designated
Because
for
I check
operations.
I go by my DFACS offices and check,
Okay.
and I've got a lot to do.
And we will get that
I've
information
got
back
so
to you.
much to do.
Chair recognizes Chair Darlene Taylor.
Thank you, Mr. Chairman. I have similar questions. From my district, the offices aren't open, or if they are open, they're not open to the public. And this went through COVID, and we understand that, but it's time for people to be back in the office. And it's a concern when you cannot get the services that they need. And it's not just one county, it's happening in a lot of places. Is there a reason why they're not open?
Ms. Tate is gonna come and forward.
Get to that, didn't you,
Thank
Jackie?
you.
I've already been talking to Jackie about it.
Sorry, as nice as I could be, it's a problem.
Good morning, everyone. My name's Jackie Tate, and I am an Assistant Deputy Commissioner at the Department of Human Services. And I did speak with Representative Houston this morning. She expressed concerns about the hours of operations. We are open to the public. However, staffing remains an issue. Since the beginning of this year, we've hired 990 OFI case managers. We have 83 more scheduled to come on board in November, but we continuously experience turnover that makes it difficult for us to have our offices fully staffed. We also are in the middle of the Medicaid redetermination process, which is causing more work for our workers because I'm sure you guys have probably heard, but back during the pandemic, the federal government asked all states to pause the annual reviews that are required to make sure that everyone continues to be eligible for Medicaid. And since that was during the public health emergency, since it was declared over earlier this year, I think it was March or April, we're required to go back and look at every case, every individual that's on Medicaid, and determine whether they still qualify, as well as reach out to them to find out what their current situation is before we can terminate them. So that's causing extra work for our case managers. We are trying to assist everyone as expeditiously as we possibly can and balance the workflow, as well as being able to speak with people in person, over the phone, manning the phone inquiries that come in. So the effort is there to do this work. We are just experiencing staffing problems, but I have noted the concerns from Representative Houston as well as the others that have asked, and I will bring that back to our leadership. I also want to make you guys aware, our office hours are posted on our website, and you all are always welcome to reach out to me or our constituent services line if you have an individual that needs some immediate attention. We do try to follow up on those as quickly as we possibly can.
Thank you.
Thank you.
Appreciate
You're
that.
welcome.
Thank you. Commissioner, Dean Green, Chairman Green has a question.
Sure.
Jackie, mine is more of an expression of gratitude to you for the work that you do for the General Assembly members. I don't think you have ever turned any of us down as you have worked to solve our many, many problems in the rural areas. So kudos to you for the work that you're doing, and thank you for what you have. And we know the issues that you are faced with the numbers that with staffing and everything. But thank you to your staff for what y'all are doing there.
I appreciate that. Thank you.
Okay. Oh, wait a minute. We have
One more
we
question.
have one more question there. I'm sorry.
Thank you.
It's more of a comment than it is a question, and I want to tell you that we all realize what you guys are going through, and through the pandemic and people getting used to not being at work, and a lot of them don't want to come back to work, and it's no different with you guys than it is the rest of the world. But what we hear is, the squeaky wheel gets the grease, and what we hear is you just as well run out on the front porch and yell DFACS as you had to try to get in touch with anybody there. It's seriously a bad problem all over the state. And that's all I'm gonna say about that. But don't think that what you do is not recognized and appreciated. The other thing that's important to me is this hoteling. I'm glad to see what's happened there, because, the two calls we get is a grandmother that's got a child in prison, or a grandmother or aunt that has no control over a nephew or whatever that's in one of these situations. And I was getting calls, and I'm just throwing this out for your information. It was strange to me, and a lot of times the child is troubled, of course, if they're in a hotel they are, and they're getting their information from that child, or 17-year-old or 16-year-old, and it may not be true. But we had an individual that was being hoteled, and they weren't from my area, but the grandmother was. And the child was calling the grandmother, I guess. The thing that red flagged me, he was in Savannah, which is on the coast. And then in 2 weeks, he'd be in Columbus, which is over on the other coast. And next thing you know, he's in Augusta. He was never in Macon, Chickamauga. Well, Chickamauga's almost on the line, but he was never in Macon or Central State. It was always on a border of the state of Georgia, and I thought that was very strange. And it was there a litany of other problems I won't even go into. The child had, plus maybe who was keeping him must have had a problem, and y'all must have found something. And so I'm glad to see the hoteling go away. But as I close, remember, we do have a problem at these offices. I don't know what it is, and as we said, what do you need? That doesn't mean you can get it, but it's a serious problem all over the state. And I'll close with just saying simply thank you, and let's all try to do better.
Amen. Thank you, guys.
Thank you so much for being here in your presentation. We're going to call on our next presenter, Georgia Department of Juvenile Justice, Commissioner Margaret Kaywood. Okay. That's not.
Good morning. I'm also joined today by Rusty Rogers, our Deputy Commissioner of the Division of Community Services, and he's going to help with parts of the presentation. Our mission with Department of Juvenile Justice is to work with our young people using evidence-based services, rehabilitative services, and supervision, and strengthening the youth and family so that they can return and be safe and the community be safe. To clarify, the juvenile court process is what drives our the youth that we receive and the decisions about where youth are placed and what level of supervision. For example, a DJJ involved youth could be a youth that it starts with a complaint and comes to juvenile court, and the juvenile court is not part of Department of Juvenile Justice. And then based upon the court and the judge's decision, the youth could be placed on an informal status where they work to place services in place or address the root cause. And then the judge could place the youth on probation, which is conditions. They remain in the community and are required to go to school and meet certain conditions for that specific youth. While they're on probation, they are under the legal guardianship of their parents. And what that also means is that they are under their parents' health insurance. And that becomes challenging, and we'll talk about that a little bit later. For more serious offenders, they can be committed to Department of Juvenile Justice, and that means we have the authority to place them based upon what our risk and assessment says they need, what level of supervision and what level of treatment. And they could be placed in the community, a residential program, or a long-term youth development center. And as our colleagues with DFACS indicated, we do have kids that cross over and are dually involved. And we work very closely with DFACS, and actually our two commissioners talk frequently about individual kids, and we're in the process of updating a cooperative agreement as we're working together. To give you a glimpse of what we do, we have 19 regional detention centers across the state. Think of those as jails. And FY22, we serve 6,111 youth admissions, total average daily population of 736. And just to let you know who these kids are, 49% of these kids in the detention center are on the mental health caseload. What that means is they met the DSM-5 clinical criteria for a clinical diagnosis and a need for treatment. And remember, these kids had just come from their home community. In our YDCs, our long-term facilities, we serve 284, average daily population of 233. 65% of these young people were on the mental health caseload. These are kids with more complex needs that have higher level of risk and offense and are deeper into the system. In our community service offices, we served 7,434, and most of those are in the community. And remembering that most of those kids are living at home under probation or under orders. And Georgia does have 19 independent courts, and they tend to be the more metro area, and that's where they provide their own intake and their own probation services. So in our secure facilities, as I mentioned, we have 19 across the state, and of those 6 are rural facilities, and these are the counties where we have a regional detention center. And then we have 6 YDCs across the state in the 2 areas of the rural, and that actually is it's Baldwin County, Milledgeville, and then Dodge County and Eastman are where our long-term rural facilities are. And so our rural facility challenges, definitely recruitment and retention is not unique to the rural areas. We have that challenge and problem in the metro and other areas, but there are different characteristics to the rural area. With our facilities recruiting juvenile correctional officers who are the direct care, direct supervisors of our kids, we have the highest vacancy rate. And then we also have teachers, remembering that we are a school system. We have counselors, medical, and administrative staff that provide these rehabilitative service. And just to give you an example, Eastman YDC, we've had a significant problem with recruiting juvenile correctional officers. And an example of the behavioral counselor is that we had posted the position for over a year and got little to no applicants, and it took quite a long period of time to fill the position. And we have also done many creative things like going to the local city council. We've met with clergy, we've met with civic groups, and we've had job fairs and then worked with others in the community to do job fairs with just minimum results. So our rural facility challenges, recruitment and retention, as I've mentioned. Just to give you an example of our RYDCs, the vacancy rate is 33%, and the highest vacancy rate, remembering, is with the juvenile correctional officer. And then an example is our Claxton facility, where we had a 41% vacancy rate. And what that means for a smaller facility is that we have 21 vacancies. And that literally means that if you have a counselor vacancy, you have no counseling services. And we actually have had to have, in the past, a counselor come from Savannah just to provide services at Claxton. And then to show you something else, in Thomasville, we actually have a very low vacancy rate. And I conferred with both the state and the local leadership of what's the difference there. And what I kept hearing was community connections and engagement, and also specifically faith-based. So other challenges we have with the facilities is, remembering these regional detention centers, these kids are there, they may be there for just 2 days, 2 weeks, a month or longer, but they return to the community. And we work with community providers around linking in the services and work with the parents. However, if those services and supports are not there, then that really limits what we can do. And then public transportation, we keep hearing both from employees, people can't come to work for us because they don't have transportation, and that kids returning home, their families don't have transportation. And then we also see that our professional staff don't want to live in a rural community that doesn't have resources and supports and other things, and that they tend to drive in for a short period of time until they find another job that has other positives. And remembering, we have service staff such as food service, maintenance, administrative, that often have their own financial and personal vulnerabilities that interfere with their ability to work. So go into our community services office. These are just some of all the services that they provide, from the case management and the oversight. And then moving right along, we have 78 community offices across the state. And in rural counties, we have 43. And in 81 counties, more than that office serves more than one county. And just to give you a couple of examples of county offices that are serving, they're almost like a regional office. So some of the services that we provide is the juvenile court intake and court-related roles. And then, of course, we supervise probated and committed youth in the community. And then we provide case management for kids that are in the RY and in the long-term facility and in residential programs, as well as being on call. And we've had challenges with recruitment and retention in our community office, similar to our colleagues such as DFACS, around both probation officers and administrative staff. In a rural area, what we would find is we would advertise and just get no applicants, where in the metro area, we might get some, but then we never are able to get them to onboarding. And most of the time we hear that it's a non-competitive salary and that probation, the long hours and in being on call is challenging. So in talking about residential programs, just like DFACS mentioned, we use some of the same residential providers that they do. These kids have to be committed to us, and that means that the judges determine we have that authority to place them. The parents may still be the legal guardian unless they also are in the custody of DFACS. And we actually have some children that are duly committed, and we work together on getting them into a residential program. For us, that court process, that assessment determines their level of supervision needs, which indicates community, residential, or long-term, and then also their treatment needs. And then that drives which residential program we would apply or submit applications. And like DFACS, these are contracted programs, and we oftentimes will have the same kids. We'll both have kids at residential programs, and it oftentimes feels like we're competing for beds, but we're really not trying to. We're really trying to work together on that. So just to give you a glimpse of how many kids we have placed residentially, that was about 164 are served monthly in about 55 residential programs. And remembering some of these are real large, such as Twin Cedar, such as Georgia Baptist. And then some of them are small that only serve 6 or 8 kids. And we almost think about those as small businesses within the community. And they have been very vulnerable from COVID to all the other challenges with that. We have not received any new residential providers. We're actively recruiting. And when our kids are screened and everything in their packet says they need a residential bed, but there's not one available, they are put on a wait list. And sometimes that can be up to 2 to 3 months. And then they sit in the detention center while they're waiting for that particular bed. And for some of them, they have a very specialized treatment needs, whether it's substance abuse or sexually harmful behavior type treatment that is needing. What we hear from our residential programs, some of their challenges is staffing, recruitment and retention, their ability to pay and compete and stay in business, and then also limited community resources and services, and then linkage and support to local school system. And this applies more to your smaller providers, that those kids are appropriate for local schools, and but however, sometimes local schools are not as receptive about being solution focused with working with them. So reentry for our youth that have been in long-term programs, say that they were a designated felon and they committed offense and they served 2 years in our long-term facility and they had completed their time. We have many kids that get their high school diploma, they get technical certifications, their GED, and they have demonstrated that they're ready for release. However, because they have that history or their family has moved on after 2 years or so, they re-enter in the community sometimes can be very, very challenging for them, of them being linked to services that are appropriate for them and housing specifically for our younger adults. And then that is sometimes when we're working with DFACS for, say, a 16-year-old returning home and the family is not equipped or willing to accept him back. We always hear about transportation as a theme from families when young people are trying to get jobs and or go to technical school. Not being able to access any type of public transportation is challenging. And then, of course, education, and that tends to be more with the local school system. So I think we needed to mention our children in need of services, which our colleagues with DFACS touched on about kids coming into custody from court. And as part of juvenile justice reform to align with national best practices, we used a different approach, and the code was changed to make status offenses, and think about status offenses as offenses that are not crimes for adults, such as runaway, truancy, and being unruly. And instead of using the delinquent model, and we would say criminalizing them, the focus was on getting to the root cause of their behavior, putting in those services in place, and then monitoring to see if that addressed the issue. And then it also limited the confinement of kids that have these type of charges. What it does, it's very dependent on community resources, and that it was not funded with any additional community resources. And I believe the only funding is one state CHINS coordinator, which is under the Council of Juvenile Court Judges, but for all local juvenile court jurisdictions, there were no specific additional funding for services or for that coordination. DFACS and DJJ and other community partners work with the judge under the judge's leadership, and however that particular community tries to address that. So in looking at what we hear from our youth and family and what we hear from our staff about challenges, it is about access to health and behavioral health services. And remembering our kids, when they return to the community, they're under their parents' insurance or lack of insurance or Medicaid. And we do have quite a few of kids that are they're dependent on their parents' insurance, and they may not have access to it or access to services. Once again, we hear transportation. And then the other thing we hear is about a need for positive youth development activities. And these would be after-school programs and summer programs. And then we hear the need for employment and supports both for parents and for young teens, for teens and young adults. And at this time, I'll let Rusty talk a little bit more about that.
Thank you, Ms. Kaywood. And thank you, Mr. Chairman and committee, for having us this morning. We appreciate what you do, and we know this is critical work. What I wanted to expand upon is what we're seeing is an uptick. Some communities are having an uptick in some youth criminal behavior, and they're struggling with addressing those issues. And so one suggestion may be that communities can do a community needs assessment to have completed, and some of those assessments would include questions related to youth and what youth needs. But not just the assessment. I think critical point and a critical piece to that would be having stakeholders come to the table to come up with an action plan to actually address some of those issues. And so that's a critical piece, not just the needs assessment, but the stakeholders coming together to come up with their own action plan for that. And some of the suggestions that may come out of that would be early intervention and prevention programs. And some of those may be restorative justice model programs. Some of those may be life skills, bullying prevention, and mentoring. And we try as an agency to do our best to provide mentors for kids that are in our facilities and for kids that leave our facilities. When they return home, we try to set them up with a mentor in some of these local communities. And so we feel that would be beneficial. But we try to do our very best each and every day to serve the kids that are with us and serve the kids that are in our communities. And so with that, I'll turn it back over to Ms. Kaywood.
So, some rural communities are more successful in addressing the challenges in their community than others. And in asking our staff, what's the difference when a rural community is working well? And what I kept hearing is that they value collaboration, engagement, and inclusion, and they view justice-involved youth as their youth, as the community's youth. And I would also add that they view foster children as their youth, that they're not DFAC's youth, they're not DJJ's youth, they belong to that particular community. And then they do have after-school and positive youth development programs, and they're specifically trying to address the kids that are vulnerable, that don't have good family supports. And then I also heard that Family Connections at the community level was inclusive of justice-involved youth in monitoring graduation rates and their other wellness factors, and that the school system is inclusive. And then I heard about communities and schools at middle and high school level that are very inclusive of justice-involved and foster children, and that was made it very successful. So in summary, what we would want to say is that when services and supports are unavailable, children are pushed deeper into the juvenile justice system for supervision, whether teens or delinquent, and that enhancing protective factors such as the pro-social involvement, strong social support, and strong attachments, and solid commitment to school actually reduces risk factors. And adolescents transition to adulthood in the workforce when they have their physical, emotional, and all their needs met within their family and within their community. So thank you. Any questions?
Thank you, Commissioner. We do have a couple of questions, and I'd remind the committee that we're still on a time limit. So if you can keep your questions down to one, that would be helpful. Chair recognizes Representative Al Williams.
Thank you. Heard that said in church too. But very quickly, as I do respect the time.
Mm-hmm.
I think you need a full-time person helping to implement the Thomasville plan all over this state. Not another job for somebody, but somebody needs to be doing that as their job.
Okay.
There's got to be an answer.
Thank you. Thank you.
Chair recognizes Representative Clay Perkle.
I'm going to try and emulate that. So I'm a cotton farmer. So the first day of harvest season, I'm picking cotton, and my cotton picker tears up right beside the road. And it's tore up for 3 days. The basket's up in the air. Everybody comes by and they're laughing. And finally, my cotton broker comes by, the guy that sells my cotton. He says, Clay, if you would just go buy you one of them new pickers, you'd be picking cotton now. And I said, if I had somebody decent selling my cotton, I could do that. In this room, you've got this young gentleman on the corner is the appropriator for the House. Do you know if the commissioner has been to this gentleman over here? So it appears that we've got a great mission here. These kids already have 2 strikes. If they strike out, they're going to be a drain on society for the rest of their life. And your mission is important. You can't keep JCOs, behavioral health. You've tried for a year to fill in Eastman. We saw from the DFAC's presentation before, they were having trouble with hoteling these kids that you couldn't place anywhere. And all of a sudden, they increased the per diem 78%, and they were able to place kids. And so money does not solve all problems, but money is a big help in staffing needs.
Right.
It appears that the weak link here is we're not paying enough for the JCOs, behavioral health people. And I would like to know if we know as appropriators, how much money it would take to solve that problem in the weak link in the chain and actually let that gentleman on the corner know.
Mhm. And actually, our commissioner, we did meet with him last year, and I'm sure we'll be coming back. And there was appropriations that we did get an increase last year, and that has been somewhat helpful. And maybe we would say that we might need a little time, or we may need to have more discussions about that. But thank you for the feedback.
I would love for you to have a frank conversation to make
Okay.
sure that, you know, if this is a step in the right direction, that we can step another full step. Thank you.
Mhm. Thank you.
I got a question on that. Do you, when we talk about salaries, do you have a pay scale that a person can come in at an entry level?
We do.
And then after 6 months, they get another raise? I'm not talking about cost of living. I'm talking about the performance raises that the state used to give.
Actually, we don't have the COLAs, but I think it was actually last year, and it was part of the discussion about the appropriations, and that we actually self-funded some of that, but we put that in place for our juvenile correctional officer, that if they stayed a certain period of time, I think 6 months, they got a pay increase, and then after 2 years or something like that. And so we really
You don't get a pay increase every year?
No, we're state employees.
Well, I was a state employee and I got one every year. Every year.
That's why I borrow
When your performance report came up, you got a pay raise. And that's what I'm saying. Yeah, now we had one every year. Not every 2 years.
When the legislative body passes for state employees to get a cost of living, then all of our,
No, not cost of living.
okay,
Not cost of living. A pay raise once a year, plus the cost of living, July 1.
we don't have that built into our financial structure.
Okay. Okay.
When y'all said get a raise every year.
Mhm.
No,
I said that's what we did when I was a state employee.
I'm sorry. I thought you meant now, because
No.
I've been there 10 years and I'm
No,
8
no,
years
no,
behind. I just
when
want
I
to
was-
make sure
When-
I want to make sure where my
when I
money.
was, when I was a state of, that was BC before Christ. Yeah, recognizes. Yeah, recognize Representative Stinson.
Good morning, colleagues. I apologize for my tardiness. I had some car trouble this morning.
Okay.
So if you're ever in need of car repairs, go to DNR here in Statesboro. They took really good care of me. So thank you. But I'm sorry I missed the presentation for DFACS. I really need to see someone from DFACS. They still here?
We've got
They
some
left.
numbers. We've got some contact information for
Okay,
you.
very good. And thank
The-
you, Department of Juvenile Justice, for being here. I'm sorry I missed your presentation, but I love to hear more from you in the future. Okay, thank
Sure.
you.
She's left her contact information. You can talk to her offline. Very good presentation. Thank you, Commissioner, for being here. Ms. Penny?
That y'all might not know about. We have call to care in my area, and if you don't have a call to care helping you with foster kids, you need to get in touch with Alice Johnson with Austin Scott's office. She's the head of call to care. It started in Tifton, and they have been a great asset to our foster families.
I'd like to get that number from you then.
Okay,
Mhm.
it's called Call to Care.
Thank you. Our next presenter is the National Alliance on Mental Health, Ms. Kim Jones, Executive Director.
Thank you very much. I am the Executive Director of NAMI, the National Alliance on Mental Illness. I also serve on the Behavioral Health Reform and Innovation Commission at the pleasure appointed by late Speaker Ralston. And I am honored to serve his legacy and to carry this forward, the movement for mental health, to make this the decade of mental health. I'm also the co-founder of the Georgia Mental Health Policy Partnership. If you're unfamiliar with that, it's a large group of 24 plus advocate groups who got together really because of the feedback we got from you, the legislators, who said, you keep bringing us stuff to put into law, we make the bill, and then you come up here and argue against each other on it. And because of that, and because Georgia at the time was 51st in the nation for access to health care, I had a little thought that maybe there was a lot of stuff that we could agree on, and maybe we should put that forward first and focus on the stuff we don't agree on last. And with that, when I was appointed to the Behavioral Health Reform and Innovation Commission, we decided to bring forth all advocates to the table. We meet every Friday at 1:00 to talk about public policy that we intend to bring before you. And that includes what we're going to talk about today which are empath units. And finally, I can't be up here and not say that I am the proud mother of a child with a mental health condition. I say that every single time and will continue to, because I'm not embarrassed to tell you he has congenital heart defect, chronic lung disease, and I refuse to be embarrassed about his mental health. We need to change that in our society to end stigma. Because I know you guys are running a little late, I want to really go over the packet really quickly. In here, you have the PowerPoint of what I'm about to present on. This PowerPoint is about empath units, but the right behind it is a one-pager about empath units on the right. And behind that is a PowerPoint on the RFP that South Carolina put forth in regards to empath, which is going to be our ask to you today. And I saw the appropriator left. We need to get them back in here. On the left-hand side is just general information. And then also in your packet, again, I'm sorry, on your right-hand side, you have frequently asked questions, because I know this group likes to ask questions. So in case I run out of time, or if you have a question, it might already be listed there for you. So with that, let's get moving forward. So, well, let me back up. What is an empath unit? Empath stands for Emergency Psychiatric Assessment, Treatment, and Healing Unit. It is a unit that goes into an emergency department to treat people who come to the emergency department because of their mental health condition. I like to explain this is how an emergency room could treat people with a mental health condition and what we see as the appropriate way. So why is this important to hospitals? 12 to 15% of the people who come forth to a hospital are presenting there because of a mental health condition. And we often hear from hospitals that it's costly to them, usually because they do not have something called an empath unit. Therefore, when people present, they are put in a hospital bed, a room with a hospital bed, and often have to find someone to sit there with them. So that is something that causes additional costs to an emergency room in a hospital. So we feel like a better option would be to build out an empath unit. So what is an empath unit? It's a physical environment that is built for acute psychiatric patients. It's complementary to the emergency department, and it allows for quick transitions to get people out of emergency departments who are there because of their mental health condition. We do want to make something very, very clear. This is not a silver bullet for mental health. However, we do feel like it is a crucial link to the very first part of what most people experience, which is a crisis in mental health. It also is crucial because as the state, you are responsible for the last resort, the crisis system, and we feel like this will prevent people from entering your crisis system that the state is responsible for managing and paying for. But as you see in this slide, there are many other parts of the behavioral health system. So this is only one small part of what needs to be fixed in our behavioral health system going forward. So empath units are already in 30 other states across the nation. Many of them are our neighboring states, and I'll provide you some statistics on these in just a moment. But what we're here to ask you about today, or what we're putting forth for this committee to consider, is a grant program that is currently being implemented by South Carolina that provided $35 million worth of grants to establish 13 empath units in the state. And you will see that empath is also recognized and recommended by the National Council on Behavioral Health. So this is a proven method for emergency rooms to address behavioral health. So we hope that you will find that valuable in moving forward with it. So what are the elements of an empath unit? It is a rapid evaluation and comprehensive treatment planning for people who present with a mental health condition at the emergency room. It includes constant observation and reevaluation while they're there, not just sitting in an emergency room or a room in the emergency department with nobody coming in and checking on them. It is a safe environment. It has a large open concept with recliner chairs in a minimum of 80 square foot total per client and 40 square foot around each chair. And that's important. If you think about behavioral health, when we get stressed out or anxious or are experiencing a mental health condition, oftentimes laying in a bed isn't helpful. That's where we think too much. A lot of people need to walk around, pace, different strategies than laying down in a bed. It has an open nursing station with intermingling staff who are there to socialize, because that's very important to mental health, discuss interaction, and provide therapy as the person is in the empath unit. It also has voluntary calming rooms, which eliminate the need for lock seclusion rooms and restraints. And that is a very big concern for hospitals. That's oftentimes where emergency room or any behavioral health or hospital staff get hurt, is during that restraining or calming process. So what is empath by the numbers? What are the treatment times, for example? Treatment in an empath unit initially starts within 1 hour of arrival. We have all probably been a part of an emergency room. It is a stressful situation if you've ever been in one, whether you're the patient or the family member who's brought them. Just the emergency room in itself is an anxious, stressful type of situation. To put someone in an emergency room and let them sit for hours on end when they are experiencing a behavioral health condition only exasperates and makes the situation worse. So having them treated or sent to the empath unit within an hour is crucial. Also, the great majority of psychiatric emergencies, like other medical emergencies, can be resolved within 24 hours with prompt and appropriate interactions. And I want to put a pin in that 24 hours because I'm going to talk about later how that 24-hour number can get us a payment path for empath. Patients typically get better in an empath unit in 14 to 18 hours, with the goal of the unit for their stays to be shorter than the 24 hours. The length of stays for inpatient admissions and return rates for an empath unit drop dramatically with empath units. The length of stay dropped from an average of 16 hours to 5 hours in an emergency room when an empath unit was present. The inpatient psychiatric admission dropped from 57% to 27%. So what that means is people who are in the emergency room in an empath unit drop from 57% going to inpatient down to 27%. Inpatient is the highest cost in most high-level acute care. So the cost is much lower when you can reduce that. The 30-day rate for psych patients to returning to an ED, that familiar faces cycle that we see often, dropped by 25%, and the follow-up, and this is why it dropped, of patients improved by 60%. The follow-up after they present in an ED with an empath unit improved by 60%. And what I spoke about a little bit earlier, the seclusion and restraint usage. Normally in a hospital without empath, there's approximately 14% rate of seclusion and restraints, which again leads to people getting hurt in a hospital, either the patient themselves and or the hospital staff. In an empath unit, that rate was less than 1%. And for advocates who care about people with mental health, that is really important to the work we do. The goals of an empath unit, we've addressed some of them here already, but just so I make sure I don't miss any of them, is we want to prevent any unnecessary admission, which will free up inpatient beds. As we know, you may or may not be aware, we just recently did a bed study. We do not have enough beds here in Georgia for the DBHDD assigned beds, as well as the beds in our private providers, which are currently going to 60% or more to people from out of state because of our Medicaid payments. It is also to provide more compassionate care, which again, as an advocate for the people we serve, we think that is the most important part of what we see in an empath unit goal. It's to improve emergency room department throughput, reduces boarding. Most hospitals complain because once a patient presents with a mental health condition in an ER, they often are stuck there until a bed becomes available. That can sometimes be 3 days, 5 days. I've heard of a child in our access committee who also had an intellectual development delay that was stuck in a hospital for a year. So that's a big concern from our hospitals that we hear. It also increases patient and provider satisfaction. This is an issue that hospitals are dealing with and having to struggle with. So we feel like having an empath unit within a hospital is a win for the hospital, as well as a win for the patient, as well as a win for the state of Georgia, because again, many of these people are waiting on a state bed. So what are some outcomes to an empath unit? Hospitalizations are reduced 70 to 80%. Boarding is reduced by 90%. Again, the average length of stay drops from 16 hours to 5 hours. Recidivism drops significantly. And then we also, in the research that was done, at one hospital, nearly $1 million was added to the ED's finances by the addition of an empath unit, making the ER beds available for other patients presenting with physical ailments and trauma. So there has been research and proof done that the actual hospital can save money in their bottom line. So what are options for empath units serving rural Georgia? We think this is an excellent option to provide care to rural areas. Empath unit additions can be added to an existing hospital facility, and that's part of what the grant helps pay for. In rural Georgia, though, what we think would be most beneficial is to have freestanding emergency departments with empath units included in rural healthcare clusters. And this can be done by a collaboration between 2 or more hospitals who could work together to have one freestanding ED unit with an empath unit included. Often we hear about, does this require a con? Currently drafted, the rural health care clusters, if you're going to do a freestanding unit, would require a certificate of need. However, we do feel like there are ways to amend the certificate of need to avoid that need of a certificate to put these freestanding units. So what do we hear today that we think is an option for rural Georgia and Georgia in general? We are asking that you copy the South Carolina Empath Grant Program. You'll see here it was a $35 million grant to create 13 empath units at an average cost of about $3 million. I would say with Georgia's surplus that we have now, I am hoping that we could do better than South Carolina would be nice. Also because our ranking in the state for prevalence of mental health, we've become the #1 state for prevalence of mental health in the nation. So I feel like we have a much greater need than South Carolina. Things to know about this request is it's one-time funding to establish an empath unit in hospitals. Hospitals can opt into this. And then what South Carolina asked for the hospitals to do back is to keep the empath units open for at least 3 years. Again, if the hospitals have similar returns, as we talked about earlier, of $1 million a year by getting people cared for appropriately and out of the unit, our hope is that they would keep it. Another key grant program requirement is that there's no wrong door facility for these hospitals for people who come there, that they provide psychiatric evaluation and initial treatment and include assessment and stabilization. And this includes referral for SUDs, that they provide crisis stabilization, and they provide peer support, which we in Georgia have the best certified peer support system. So of course, we would expect that to be a part of the empath unit, and is proven to be one of the number one things when people are in recovery to keep them in recovery, is having a peer who's been through the lived experience. Also, to coordinate with community providers to ensure there is care after they leave the emergency department, and that the emergency department will discharge and transfer patients to the appropriate level of care. And to end this and hopefully leave us a little time for questions and keep us on track for your schedule, I just want to give you an update. The the National Mental Health America ratings for each state in our nation has come out. And we are currently, as I said, #1 in prevalence for mental health in the nation. We are also #1 with adults with substance use disorders. And we are also #1 now in adults with serious thoughts of suicide. For youth, we are #2 for youth with substance use disorders. And we dropped from being 48th to access to care to 49th in access to care. And as we heard many of the presenters before me talked about, we are ranked 47th in the availability of mental health workforce. So that is where our numbers are today. And as everybody here knows, we have quite a surplus, and there are more numbers that are out in regards to our youth and mental health. I think they are very scary if you get a chance to look at them. And so my question for you guys, if it not now, when? When is a better time when we have the surplus to help the people in need and get where we need to be than now? And with that, I'll open it for questions.
Chair recognizes Chairman Hatchett for an answer or question.
No, I have questions and statements. I don't have any answers. Kim, thank you for what you do and for all your advocacy and just everything you do. So missed part of your presentation, and forgive me if I ask a question
That's okay.
that you stated. Is Commissioner Tanner on board with the empath
He
facilities? Okay. Has he requested money? Do you know?
Not that I know of.
Okay. And I hate to hear all those categories and things that we're winning and losing in. Neither one of them we want to be winning in. And
That's right.
so, but thank you for what you do.
Oh, thank you.
Chair recognizes Dean Green.
Thank you for your presentation. I live close to the Alabama and Florida lines with my constituents. I had a doctor to call me the other day, and she had referred a patient to a hospital. He was in the emergency room 24 hours, being a suicidal person. Those are the type of issues that we have. We do not have in rural Georgia the hospitals that are close by. They were closed, and we have issues there. And one of the things that being on the border, when we find a place like in Alabama that can take someone, their bill becomes a huge problem for them to meet because we don't pay.
Right. Absolutely. I couldn't agree with you more. As I said, we do not see this as a silver bullet. What we are hoping that if we take care of people appropriately in the beginning, we will reduce the number of beds that your patient was waiting for. Because as you saw, this reduces the number of people who would have to go into inpatient beds, which means it would open up other beds for the people who really need them, as you spoke of in the story that you told.
Mr. Chairman, can I?
Go ahead.
How do we in the rural areas meet the needs of those beds, though?
Well, this is one, as I said, this is not the silver bullet. There are many other things. One of the things that we are recommending and was in House Bill 1013 that you guys graciously passed was the rate study. And one of the things, I think somebody else mentioned it in one of their other presentations, when the rates go up, the care somehow happens. As I mentioned earlier, 60% of our beds currently in Georgia go to out-of-state people who live out of state. And it's because our Medicaid payment is one of the lowest reimbursement rates. And the only way to fix that is to increase our reimbursement rates.
Chair recognizes Chairman Parrish.
Thank you, Mr. Chairman. Thank you for your presentation. It's pretty impressive, some of the numbers that you had there. My question is this, so when you look at the goal is to try to reduce that, say, less than to 24 hours and the numbers, how they go down like that. My question is, would you elaborate a little bit more on that and what happens after the 24 hours?
Part of this program requires them to connect them with community care. So what is a part of what the grant proposal is and to be an empath unit is that you have to connect them to people within your community. This also would have skilled people in behavioral health in the unit themselves. So they would provide a care plan. If you saw on the list of things that they have to provide, when they leave the unit, they would need a care plan. That currently doesn't happen right now when they leave the emergency room. They're referred to an outside provider to create the care plan. This allows for them to create the career plan there in the ED.
Representative Higgins.
Thank you, Mr. Chairman. Thank you, Kim, for being here with your presentation. I'm curious about something. I don't know if we've got this information or not, but do we know if there are particular diagnoses that benefit most from these empath units? Do we have that information from the states that have these in place, or is this a situation where they don't have a diagnosis and that's part of the problem?
Part of what this is all about is creating the environment. So I would answer that, yes, this is the correct environment for somebody with a serious mental illness. And for anybody who is experiencing in that, I have not seen those numbers, so let me say that. But from just knowing behavioral health, this is the correct way to handle a behavioral health situation. So my answer to that would be yes. That these are for serious mental illness such as schizophrenia, bipolar, those type of illnesses that often are the ones who are picked up by the police for other issues. This is the correct environment for have them. And just so you know, this is also mirrors very much, and my DBHD friends will be up next, what currently the CSBs are doing in their crisis service units. However, many of those CSBs, consumer service boards, which when you have the name consumer service boards, the public doesn't know where to go, are often not in a place where people can easily find them with names that could easily be found. For example, one near me is in an industrial park. So making sure, and I do not believe we'll be able to change the public's idea of when something goes wrong, you go to the emergency room. Also, mental health presents in many similar symptoms to other conditions. And mental health is the only condition that the public is supposed to diagnose somebody to know where to take them. We, as advocates, that's a little discriminatory, but we're not going to go down that path right now. But people go to the emergency room. My loved one is acting differently. They're not communicating clearly. That's just the first place they're going to go. So I don't know if that answered your question completely, but I can find out for sure afterwards as well. Thank you.
Representative Al Williams.
Thank you, Mr. Chairman. Very quickly, when I looked at your layout on future possible impact facilities at hospitals, I noticed Southeast Georgia, which is in Brunswick.
Mm-hmm.
And keep in mind, I was at the Pentagon on Tuesday,
Mm-hmm.
and they're looking very closely at what we're doing because we're going to lose a huge amount of troops, unfortunately, in the next round of cuts.
Yes.
And one of the things they're looking at is the families of these folk who are not necessarily treated at military hospitals, but people follow them. And I think an ideal place to take a look would be Liberty Regional Hospital because of the importance. That's one of our, we never talk about it, but that's one of the largest income producers in Georgia. That's our military bases.
Wow, I didn't know that myself, so thank you.
yes.
Couldn't agree more. The great thing about the grant program, and it would allow for collaboration between any rural hospitals or through the community. And definitely, I think that's a good point to make.
Thank you, Mr. Chairman. Thank you for your presentation. On the cost of the grant, $3 million average cost, does that cover the facility, staffing, operating cost?
You know, it's a grant to the hospital, and it depends on what the hospital wants to do. The cost to run an empath unit is $3 million a year. So however the hospital wanted to use it, they could use it to capital to build out, or they could use it for staffing or whatever they may need. So that's a part of the grant process in the proposals that are submitted.
Okay, thank you.
To give you some contrast in that, our understanding in the Access Committee presentation on empath, a CSB cost $8 million to run. A CSB's crisis unit cost $8 million.
Thank you. We appreciate your presentation.
Thank you. And I want to thank each and every one of you for your support of mental health over the past couple of years. If you voted for House Bill 1013, thank you very much. I appreciate it.
Thank you so much. Our next presenter and our last presenter will be the Georgia Department of Behavioral Health and Developmental Disabilities. And Ashley Fielding, the Assistant Commissioner, will introduce her staff.
Moving right along. Impressed with my leadership.
Yeah, well, got to be out of here by a certain.
Got to go. Yeah. Tell them. Stay alive. They need help.
Good morning.
All right.
Thank you all for having us here today. On behalf of Commissioner Tanner, my name's Ashley Fielding. I am Assistant Commissioner for Agency Affairs. I'm here today with two of my colleagues, Dante McKay and Logie Ruffin. They are two of DBHCD's best and brightest, and they're going to speak a little bit later about some of the services we provide for youth in the state, which was the request of the council. But if you'll allow me, I want to speak briefly, and I promise, Leo, it will be less than 5 minutes, so I'm going to keep to that, on some of the things that we at DBHCD are tracking and responding to in terms of mental wellness in the rural areas of our state. So this first slide is actually not DBHCD data. This is published by the Department of Public Health in the OASIS system. What we have seen in rural areas is an increase in suicides of about 66% over the last 20 years. We actually saw a peak in 2020, and you all know some of the reasons for that: natural disasters that affected some of our farming communities, and also just the stress of the COVID-19 pandemic and the isolation that came along with that. The data is actually a depiction of the death rate by suicide, which DPH also provides, and that's been a 25% increase in the rate over the last 20 years. We've seen the number drop slightly in the last 2 years, but again, it's overall been a 66% increase over the last 20 years, and that is a higher rate and a higher rate of growth than in our non-rural areas. Now, this is actually DBHCD held data. Some of you may know, and if you don't, I'll just take a moment to explain. DBHCD operates by way of management the state's crisis phone line. For several years, the last 15 years, that's been the Georgia Crisis and Access Line. We receive calls from two different paths. One is our Georgia-based phone number to the Georgia Crisis and Access Line, and the National Suicide and Crisis Lifeline. Last year in July, that phone line on the national level was rebranded to 988. And not only was it rebranded, the scope of services that were provided through that line also expanded. So instead of just being a phone number for individuals who experience suicidal ideation or are concerned for a loved one who may be experiencing thoughts of suicide, It now also supports individuals who are concerned about substance use disorder, whether it's their own or another person's, and also just need someone to talk to in a moment of despair. Because that line is anticipated, and we have already experienced, to increase our call volume and the impact on our downstream services and our crisis continuum, we have started tracking and publishing data as it relates to our crisis episodes in the state since it launched in July of 2022. What's on the screen is what we've seen and experienced in our call volume by county since July of 2022 when 988 launched. This is data by county, and that is reported by the person who calls, who can choose whether or not to share that information with us because our calls are confidential, and then weighted by population. And what we have consistently seen over the last year and 3 or so months is that the majority of callers are coming from rural areas of our state, and particularly southern counties in Georgia. So I see some of your faces. Why might that be? Well, first of all, it tracks with the data that we see from the Department of Public Health, just in terms of the rate of deaths by suicide in rural areas. But then anecdotally, we are still figuring out some of this, and that's why we're tracking some of this data. Anecdotally, we know what you all know. Access to outpatient services is limited in rural areas of our state, just in the same way access to cardiologists and other forms of healthcare are. And that means that people in rural areas may be more likely to enter the system at the point of crisis than earlier in the road when they start to experience just some early symptoms. The other reason is, quite simply, as a person who comes from a rural area, it's just the reluctance to both accept and reach out for care for issues of mental health or substance use disorder in areas like this. The crisis call line, which is where this data comes from, is anonymous. And so that may be more attractive to individuals in rural areas rather than somebody seeing your truck in the parking lot of the therapist's office downtown. And so we're continuing to watch this and consider how we respond. Speaking of response, I'll touch on a couple of things on this slide, and then I'll turn it over to my colleagues to get to the presentation you all requested. But I want to speak to two things on this slide, specifically the investments you all have made in ensuring those individuals in rural areas who reach out for support are able to access it. In the last 2 fiscal years, you all have made tremendous investments in crisis bed capacity in Columbus, Augusta, and in Dublin, which allows us to make sure that individuals who reach out in rural areas are able to access a crisis bed should they need one. You also invested just this fiscal year in additional support for our mobile crisis response teams. Those are clinicians who, if you call the crisis line and our call center can't quite figure out what level of care you need, they respond in person. They evaluate you. They talk to your family members or other people who are there to better understand and assess the situation and determine and work with you to agree to the type of care you might need. That might be a crisis bed. That might be an outpatient appointment tomorrow. That might be 23-hour observation. We have seen an increase in demand for mobile crisis response services over the last several years, about 40% since 2020. And as a result, our response time has gone up. The national standard for this is about 60 minutes or less. And so this $6.2 million investment will help us get closer to that, especially in rural areas where our clinicians have to drive further. And then one other thing I want to note, 988 will be marketed on a national level, and some of that is already starting this fall. We in Georgia are not investing our dollars in mass marketing. We are focusing our effort on educating the communities we know are at higher risk for suicide. So of course that is, based on the data we saw earlier, our rural communities. Just last week at the Sunbelt Agricultural Expo, we launched what will be the first of several listening sessions with our farm communities The goal of this, we're partnering here with the University of Georgia College of Agriculture and Environmental Sciences, Mercer School of Medicine, Center for Rural Health, and the Department of Agriculture. The goal of this is to talk to members of farm communities, so farmers and their peers, their partners, and faith leaders about how they perceive issues of mental wellness, how we can better understand what affects their mental wellness, and then improve how we communicate with these communities about resources such as 988. But ultimately, what we'd like to do after we get through these listening sessions is better understand how our providers in those communities can better serve individuals in farm communities. What we want to do is make sure those services are advertised and provided in what is essentially a culturally competent way. So I'll be happy to answer any questions you have, but without further ado, I'll go ahead and turn this over to my colleague, Dante McKay.
Good morning to the chair and to the esteemed members of the council. Thank you for the opportunity to share remarks this morning. Again, my name is Dante McKay. I direct the Office of Children, Young Adults, and Families in the Behavioral Health Division at DBHDD. The primary target audience for the services, supports, interventions that my office funds are for uninsured or children, young adults that have traditional Medicaid, also known as SSI Medicaid, and those that are in some cases underinsured. Our two primary goals are to invest in infrastructure that supports individuals that receive Medicaid or again are uninsured. And then we develop non-traditional programs that support traditional services that are available through Medicaid. And we'll provide some examples of what those look like. This is a reflection of how we work with the Department of Community Health. The majority of children in Georgia have a payer. You hear a lot about payer, meaning insurance status, whether it's with private insurance, whether it's with managed care Medicaid, whether it's with traditional Medicaid, and then a small portion of children are uninsured. But what this slide represents, reading from left to right, big oval is Department of Community Health to your left, and Department of Behavioral Health and Developmental Disabilities, DBHD, to your right. The 4 managed care organizations are contracted through DCH. They sit to your left here. And then we have, again, primary responsibility for your uninsured, which is the single oval or circle in the oval to your right. And then there's shared programming between the two agencies. You'll see there's some overlap, and that is population is fee for service and individuals that qualify for waivers. And then that bottom circle to your right is when an individual is underinsured, meaning they may have private insurance, they've reached their maximum benefit. An example would be if they're in a psychiatric residential treatment facility, their authorization is about to expire. The doctor says this person is not ready to discharge. The insurance says, well, we're done paying. The department steps in to cover those services so that people are not being discharged prematurely. And I failed to mention on the last slide that the age for my office is age 4 up to age 26. So from 18 to 26, we consider those to be transition age young adults. This slide represents how we think about, plan for, evaluate services. This is called the Child and Adolescent Continuum of Care. In the interest of time, I won't go through all of these. I'll just spend some time talking about those that are highlighted in orange up here. But to give you a sense, I think you can read it, but I'll just read it real quickly. So reading this left to right, we think about services from prevention, early screening, column on your far left. Next, early intervention. In the middle, intervention. To the right, late intervention. Those are going to be your inpatient or high touch kind of services. And then things that span the continuum. So there's a little stripe at the bottom. These are things that we invest in that span the entire continuum. First, I'd like to share just an update on Free Your Field. So this is a mental health wellness campaign targeted to children, teens, young adults. It is something that is available in rural Georgia. It is a campaign that we partner with Voices for Georgia's Children and Silence the Shame prior to the pandemic, and it remains a well-received, well-adopted mental health outreach campaign. This website is listed at the bottom, but essentially it is designed to encourage young people to not internalize their feelings, but to share them. And that way they're able to connect with individual services and supports that are appropriate to their needs. In terms of how many we've served this year, the number of children reached is 1,908. So from January to June of the first part of this year, the number of adults that we've reached through the campaign are 670, and about 22,000 we are unsure of because they have an opportunity to share their age or not to share. But in total, through the first 6 months of this year, we have engaged over 25,000 individuals. So in addition to things like a toolkit that you can go to the website, download, schools have started to adopt this. It's really taken off in places like Liberty and Pike counties. This year, we're incorporating teen summits, 3 of them. One is focused on rural Georgia. And this year, we have also added suicide intervention trainings throughout the state. The next couple of slides, we'll talk about what's known as the Georgia APEX program. It's our school-based mental health program. And essentially the model is to, well, before I share the model, so DBHDD does not provide direct services. We contract out through a provider network. Earlier it was mentioned community service boards. That's our tier 1 community safety net providers. DBHDD also works with traditional Medicaid providers. They bill Medicaid, but we contract with them for specialty programs like a Georgia APEX program. And then the model is to contract with a provider to embed a therapist and other parapros within school settings. And depending upon the workforce or the relationship with the school, a therapist could be there every day per week, could be 1 day per week, could be half a day per week. But it has increased services meeting children where they spend the majority of their time. The areas that have gray on this slide are areas that does not have an APEX implementing school. The program is in its 9th year. We have engaged about 800 schools, and we have close to 400 therapists embedded in those schools. These are some of the data points that we track. We closely evaluate the program, how it's performing, what the gaps are, how well it's doing. And these are just some of the data points. Things that we look at are the services, the type referral sources, the type diagnoses, how much is in person, how much is provided through telemedicine services, and then how parents are feeling about the services that they're receiving. It's mostly in elementary schools, and then you'll see middle and high school about even, and then your alternative schools. And then in terms of distribution, it's almost 50-50 serving urban to rural Georgia communities. The next couple of slides, we'll talk about clubhouses. Throughout DBHED, there are 3 offices that offer 3 different types of youth clubhouse programs. The first being a prevention clubhouse. Prevention clubhouses essentially there may be some family history, there may be initial behaviors that are starting to manifest. And so children and their families are able to become members of those clubhouses to intervene and hope to prevent that them going deeper into services or having greater needs. There are 3 clubhouses operated around the state, and then there's a plan to add 2 additional ones in this fiscal year. and currently adding a virtual statewide prevention clubhouse model. To date, approximately 180 youth are served per year. And those clubhouses, are operated by the Office of Behavioral Health Promotion at DBHUD. The mental health resiliency support clubhouses are operated directly by my office. Think about boys and girls clubs that are therapeutic in nature. It involves support to both the youth and the caregivers. And we operate about 15 throughout the state. Most are located in suburbs or rural Georgia communities. And last fiscal year, we served over 1,000 youth. Two others are our youth addiction recovery clubhouses operated by our Office of Addictive Diseases. These are individuals that have substance use treatment needs and support. So again, think about Boys and Girls Club, therapeutic in nature, but the primary treatment modality relates to helping them with their substance use challenges. They are sprinkled also throughout Georgia, serving rural communities, and approximately served 222 youth in the prior fiscal year. And then lastly, Kate's Club is an organization that we've partnered with for about 2 years now. Their focus is to support youth that have lost a loved one, a peer, a caregiver, a friend very close to them. And so it's a grief support clubhouse model. They operate an in-person Atlanta and satellite sites around the state, and also have a statewide virtual model that they're operating. And in fiscal year 23, we served approximately 2,069 youth. Intensive customized care coordination is a statewide program. It's a Medicaid service operated by now 4 providers. I'll show you a map on the next slide. It's been around for about a little over a decade, but it is case management at its highest level. It is a high touch, high fidelity wraparound program that involves peers, whether it's a youth peer or a parent peer, someone with lived experience, with a care coordinator, with the therapist, but the families get to call the shots. So the youth and the parents are the ones that are directing their care with the support for these skilled individuals, and they also get to incorporate natural supports in that. So if it's a pastor or a mentor, they can be a part of the care model. It's high touch, at least 3 times per week, and case managers cannot have more than 10 individuals on their caseload. But it is really to wrap around the child to support their needs. And this is also considered a community-based PRT level, or psychiatric residential treatment level care, but in the community just because of the high touch nature of it. So this is a map from a couple years ago. Again, through the years, there's been some growth and some contraction of this program, but a couple years ago, we were left with 2 providers serving statewide, and you can see the areas in gray there are areas that were underserved. And so in the last year, year and a half, we have released procurement, contracted 2 additional providers, and ramping up. And so if I get a chance to talk to you again this time next year, my hope is that there won't be so much gray on this slide. I think that's it for me, and I'll welcome up Logic.
Good morning. My name is Logic Ruffin. I'm a forensic peer mentor and trainer and liaison for DBHDD at the Office of Adult Mental Health. And I'll be talking about the forensic peer mentor program. I like to share stories. Stories kind of be more impactful, and they kind of prove that what we're doing is have a lot of impact. So my story, I was a troubled youth that didn't really understand mental health or substance use. They were not using them terms in the community that I was in the 80s. It was a lot of stigma tied around it. They just referred to it as crazy. And within that, I just didn't really understand and didn't really know where to get help. You know, when we hear about a lot of these services that we have now within my community, we didn't even know them services exist. So, you know, my service was addiction and self-medicating and committing crimes and harming individuals. And from there, it landed me within the youth detention centers. And I went into the Department of Corrections with a life sentence as a teenager. This right here kind of really hurt my family, really tore apart my family, because we didn't really just really understand what was really going on. So when I got inside of the Department of Corrections, it was individuals that was going through the same similar stories. You know, we hear the same stories that kind of just really would just help me kind of find my voice, to really kind of just find out what I need and how can I get the services I need. So I started kind of really just on my journey within the Department of Correction to just really educate myself, really kind of receiving services, going through classes to help me with my anger management, help me really just understand what was going on with me mentally, and really kind of just really get a grip on it, just my substance misuse, and just really how can I just really just kind of curb that and be just in empowerment with that. And within that, going through several years within the Department of Corrections and just growing up within the Department of Correction, this is when I just kind of just really just found my turning point. So I started taking classes, and I got into this particular program, the Braille program, where I learned how to produce books for the blind. So after doing 22 years inside the Department of Corrections, I made my transition. Into the Governor's Mansion program. At the time, I worked at the Governor's Mansion as a trustee up under Governor Deal. Governor Deal was a very big, huge individual there for criminal reform. And he not only talked about it, but he actually participated in it. You have to think about it. I was a child going into the system, so I didn't know about right time. I tied. The first time I learned how to tie a tie was Governor Deal taught me right there in his room while I tied it. Then he take it loose, and I tied again. And Mrs. Deal was very, very impactful. She was a school teacher, and she really was just fascinated because I knew how to learn how to do Braille. Mrs. Deal was the first person that I actually got a hug from. After doing 22 years within the system, she really hugged me. She really understood that, you know, I just needed that particular type of contact. At times, you know, it's just been a year since a transition, and it very hurts me to just really I'm surprised I'm getting through this presentation, because I normally kind of get hurt, because even after their term was over with within the Governor's Mansion, they still continue to keep up with me. They still continue to invite me over to really just kind of just really be proud of me and just how I just navigate through the system. So I end up creating my own Braille program, my Braille company, where I learned how to produce books for the blind and teach individuals and really find voice for individuals who visually impaired and blind. And I started my company. They helped supporting me within that. So I found an interesting program called a Forensic Peer Mentor Project, which I'm gonna go a little bit more into it. But I became a forensic peer mentor because I was once previously incarcerated. So I wanted to go back within to kind of just really help individuals that couldn't find their voices, what mental health is, what substance use is, what are really happening to you. So I was very privileged to work as a forensic peer mentor at the time for Georgia Mental Health Consumer Network, and really find that support to really help individuals transition within the community. Also, my educational accomplishments, which Governor Deal and Mrs. Deal really supported me on. I graduated from a program from Morehouse School of Medicine. I currently attend Mercer University. Go Bears! I went through a crisis intervention team, CIT, where I actually trained with officers. This was the first time ever that I actually trained with police officers to kind of help them really just understand when somebody go into crisis, what they can do and how they can really just be a benefit to the individuals. Also, being a forensic peer mentor is about partnership and partner with government. When I partner with the U.S. Attorney Office of Northern District, where they have a program called Project Safe Neighborhood, where they work with individuals with youth and gangs, that we go in and we really help them really just understand and help them turn that corner. Also, my new beginnings after serving 23 years in the prison system. I've been out 7 years now. The parole board commuted my sentence where I don't have a life sentence anymore. So that gave me my right to vote. So I voted for the first time last year. I got married to my beautiful wife in 2020. Me and my family are back together and thriving. I have a daughter. I have 3 grandkids now. So really just to help them really just what put us back together. And then I got hired by Department of Behavioral Health. And this was something revolution because, I had a criminal background and working for state government, a mechanism popped up to say, hey, you can't work. But the one thing that our Commissioner Tanner did, that, he with conversation with Governor Deal, they basically just said, if anybody can give a second chance, Department of Behavioral Health can give an individual a second chance. So that was my new beginning. So I'm going to talk about the Forensic Peer Mentor Project. So the Forensic Peer Mentor Project is individuals that have criminal justice lived experience, have lived experience with mental health, and have lived experience with substance misuse. And one thing I just love to just read at the last bullet is that, they operate from the perspective that everyone who lives with a behavioral health disorder and criminal justice involvement have the capacity to recover and live a successful lives and meaningful purpose in the communities of their choice and free from further criminal involvement. And this is what the Forensic Peer Mentor basically does. We have a caseload from 2020 to 25 is our max. We help individuals in the criminal justice system with whatever their reentry plans is, whatever their plans is to really help them be successful. The Forensic Peer Mentor sits down and help them with their plan. It's not the Forensic Peer Mentor plan, it's their plan to get them to encourage, but they come out of a system that everything is done for them. So we empower them to empower themselves to go find the linkages because, 2 o'clock in the morning, I'm asleep. So if an individual trying to call me to try to receive services, he or she knows how to get that service while I'm 2 o'clock in the morning sleep, right? And that is the best thing that we do. And then, reduce psychiatric hospital visits. This is the one thing that Forensic Peer Mentors work because we don't want them to go back into the criminal justice system. We don't want them to go to jails, back to prisons, back to hospitals. We want them to stay whole. Other things that we work on, we work on life skills, we work on transportation, we work on addiction treatment, we work on housing, we work on education, anything that would make an individual whole. Like I said, this is their plan. This is not our plan. Even family reunification, we really work very hard with that because we understand that the families have maybe been affected while they've been incarcerated, or has been dismantled, but we really try to help them kind of just put their life back together and put the family life back together as well. DBHDD, we currently fund 34 sites. 27 of them is inside the Department of Corrections. 7 of them is the Department of Community Supervision. That's parole and probation. And this is where we have forensic peer mentors working full time. Our success stories and future projects. One of the things that I definitely would love in the direction that we're going in is that we started talks with the Department of Juvenile Justice to embed forensic peer mentors within their facilities. This is the one thing that, I definitely push for because me being a youth that coming out of DJJ, I felt that it was vital to have forensic peer mentors there to really just help individuals kind of just navigate their mental health, navigate their substance misuse, navigate going into the world because you have individuals that been in and out of these systems. So the forensic peer mentor is there to help them kind of support. So we're in currently conversations now to really just help them stand that particular pilot program up. Also, I had the privilege to go inside of one of the DJJ facilities in Eastman's to talk to the young men there, to really just help them just give my story and just really just help them to support them, to let them know that, hey, you have a voice and we're here to support you. And it was a lot of conversation there, and I really just had a real nice time, just really just kind of just understanding them and just really just listening to them and really just sharing my story of success to let them know that it is possible. That's just the thing. Some of these youth coming out of communities that they feel that it's not possible. So just seeing me just really just lit them up. We also another thing about being a forensic peer mentor is just being part of a community. We work with individuals that the biggest thing within the youth culture is gangs. We really work with them and we really work very hard to kind of really just help them curve them way from gang violence, period, criminal behavior, criminal activity. But these are the things that we work in right here in the picture is me within the community, just really just being there as a force. And that's what forensic peer mentors are. We're not only just there for our peers that we provide services for, but we also there for the community as well, to serve as a beacon of hope and just serve to just help wherever that we need to help support individuals, the youth, to really just help guide them into a proper place. And that will close my presentation, and I guess we open for questions.
We certainly appreciate your presentation and your testimony, and we believe that it's been beneficial not only to you, to others that you have come into contact with. Unfortunately, we don't have time for questions, but we would ask that you stick around for a while so that members of the committee can get with you, and if any questions they want to ask you, that they can get back with you. Unfortunately, we're running up against this Georgia Southern football, and football is the next season after summer in Georgia. So we have to abide by it. I'm going to turn it over to Chairman Green.
Thank you so much for that presentation. That was really uplifting and everything. And please do stick around because there are people that wish to ask you some questions and things. I have the honor to present a man that is making a difference in the area of education. And I would like to call right now the president of Georgia Southern University to go to the podium and to talk about my alma mater and Butch and who else. We've got several from Georgia Southern here. But President, go ahead and take the time now to speak to us.
Well, good morning, and thank you so much. And Mr. Ruffin, you may be a bear, but you're welcome to be an eagle anytime. Come join us. Awesome story. Thank you for sharing that. Chairman Green, Chairman Jackson, and members of the Rural Development Council, thank you so much for spending your time here with us yesterday and today. Thank you for the dinner. I want to thank everyone that has been here, and also the people in this committee that are delegation. I want to thank you for the work that we do hand in glove together. Lisa Hagan, Butch Parrish, Al Williams, thank you for your work and representing us in this region so much. I want to thank Speaker Burns for being here yesterday, and then, of course, he'll be back for the football game tonight. He represents the entirety of the state and us so well. And my partner, Lori Jordan at Ogeechee Tech, for hosting the dinner. I think we all had a wonderful time of fellowship together. So it's been a great couple days, and I know you're at the end here, but I do want to tell you a little bit about Georgia Southern and how it aligns specifically with the work that you do in this important council, and thank you for your work here for the state. We're 26,106 students in 3 campuses. Statesboro, Savannah, and Hinesville. We are at the epicenter of what growth will be happening over the next 10 years. In fact, the projection of migration and growth is 20 to 30% in this region. So in terms of our ability to elevate, raise, develop talent over these next years will be with partnerships, with our education collaboratives, what we do together with our technical college, with our public school system, to ensure that pipeline of talent coming through. Now, we talk a lot about what we are doing in higher ed, but I think the difference for Georgia Southern, and particularly I think Chairman Hatchett and others, it's important for us to be accountable. You all fund a major part of our activities and what we do. And so at Georgia Southern, we have balanced scorecards that we publish that are public facing, that you can go and see exactly how we're doing based on the goals that we've set on data-based measurements. You can see my 90-day actions, my cabinet's 90-day actions, and see exactly what we're accomplishing, where we're missing the mark, where we're moving forward. Transparency. And with that, what that has led to, particularly in the last 4.5 years, are records to this institution. $1 billion annual economic impact to the region, record to Georgia Southern, record fundraising in the history of the institution, record 4- and 6-year graduation rates in the history of the institution, and record research awards and expenditures in the history of the institution. What I'm proud of is what you heard yesterday also at the beginning, which was an incredible example of our public impact research agenda. The 5 areas of research that we're focusing on will have impact specifically on Southeast Georgia. And you heard from 2 of our superstars, Dr. Jessica Schwind yesterday with the Institute for Health Data and Analytics, and Dr. Asli Aslan with the Institute of Water and Health at Georgia Southern. Those are 2 of the 5 focus areas that we're devoting to make sure that our communities continue to elevate with the research we do and the services we provide. Some of the other focus areas, as you can guess, are logistics and supply chain. We're leaders in that area with PhD all the way through in programs. In fact, we're 25th in the world of research productivity in supply chain. For us also, we look at advanced manufacturing. We are the only advanced manufacturing engineering program in the state of Georgia, and that combined with what we do in electrical engineering is exactly what the automotive industry, and particularly Hyundai Motors as they're coming in, need for us. In fact, we've had 3 career fairs. They've hired over 30 of our engineering students already, and we will be a pipeline for them as they come into this area, and we see that exponential growth as we serve them. We just signed an MOU with Hyundai Motor Group Metaplan America to create then a pipeline in partnership with Ogeechee Tech and our other educational partners to make sure our curriculum is aligned, our research aligned, and that pipeline of talent continues for now and into the future of that demand and need. So when you think of us and you think of the future, one, welcome here, be ready for our growth and the part that we play as the epicenter of growth in this region. I couldn't be more proud of what Georgia Southern is doing and to serve this state and to serve you here in your committee, because we do represent not only rural but also urban areas in a combined 10 to 12 county region that has the full spectrum of the needs of this committee and then what the state needs. So thank you for being here today. And if you're traveling home, please have safe travels home. But most importantly, if you're staying for the football game, make sure that you hail Southern. Thanks so much for being here.
Thank you, Mr. President. We thank you, and we certainly appreciate your staff. Anna Lee has been so helpful to us, and so was Brian, and all of the people that helped us through this occasion here. And you have been a great host for this committee, and we just really thank you for that.
Our pleasure, Chairman Green. I do have one footnote here just because it's important and somebody that we hear. Anna Lee Ashley does an incredible job for this institution, for this region, for me as my chief of staff, and she is now Dr. Anna Lee Ashley as of last week. Congratulations.
That's great. Thank you so much. Members, a few little things right quick. All the presentations have been sent to your email and posted on the website. If you have any questions, talk to Leo about that. Our next meeting is in Athens. Look at the dates, November 16th and 17th. Hotel information will be sent to you next week. Check your email. And John Corbett, you're in charge of making sure that Mr. Perkle has the right hotel. The agenda will be sent out soon in the next week. See Stacy for your mileage. And if there's no other questions,
Representative Williams has one.
Very quickly, the chairman and the members of this committee, we have an emergency that was not present as critically as now. And I'm asking this committee for an emergency hearing on the shrimping crisis on the coast of Georgia. We've seen, because of foreign dumping, we've seen wholesale prices for shrimp go from $3.50 to $4 to 85 cents a pound.
ooh,
And we're about to lose the entire industry. And I ask for an emergency meeting as soon as possible to discuss what we can do to save this 200-year-old industry.
thank you. We will certainly provide some information and work with you on doing this. That's important to our area.
One thing I want to say is the media staff, we want to thank them for traveling and being here with us from Atlanta and making sure that everything is online. Also, Leo and Stacy, thank you for the work that you do for this committee.
Thank y'all so much. We are adjourned.
Bye. Drive carefully.